Hello everyone. In this session, we will learn about the analgesic ladder, which is proposed by the World Health Organization. Learning objective of this session: at the end of the session, you will able to learn about what is analgesic ladder, describe the key concept of analgesic ladder, explain the principle of analgesic ladder. What is analgesic ladder? Analgesic ladder was a strategy proposed by the World Health Organization (WHO) in 1986 to provide adequate cancer pain relief. In 1986, WHO developed a simple model. This is the model for the slow introduction and upward titration of analgesic, which became known as the WHO analgesic step ladder. So when it was proposed, it was unidirectional. Unidirectional, it means that like in this model, you can see the numbered blocks, numbered ladder, that is 1, 2, and 3. So one is having or consisting of those drugs which reduce the pain, or which is also called as an analgesic, but having a non-opioid drugs. We will discuss later about this model. Then second one, which is consisting of a weak opioids, and the third step or third ladder, which is consisting of a moderate to severe pain drugs, that is known as the opioids drugs. So previously, when it was proposed, it was working on the basis of unidirectional. It means that when a patient requires any drugs, it has to move from bottom to top, but several modification and several revision has been done over the years on this ladder, and currently it is applied to both cancer and non-cancerous patients. Along with that, it is applied for those who is having acute pain and those who are having the chronic pain as well. So currently it is applied into the variety of pain management techniques, and it focused on the quality of life. Along with that, it is changed from the unidirectional to the bidirectional approach. So it is intended as a bidirectional approach, and currently it is applied for managing cancer pain, but also the acute and chronic pain, non-cancerous painful condition due to the broad spectrum of disease conditions such as degenerative disorders, which includes like multiple sclerosis, arthritis, Parkinson's disease, muscle dystrophy, musculoskeletal diseases, neuropathic pain disorders such as facial nerve pain, stroke, phantom limb pains, and other chronic pains which duration is more than 6 months. So this is about the analgesic ladder. Next, the key concepts of the ladder. What is we need to understand here that whenever a patient come with the pain, first we need to understand about what is pain. So we should have adequate knowledge regarding the pain, that what type of pain the client is having or the patient is having, since how long the patient is suffering, and what is the intensity of the pain. So it is very important that we need to assess the degree of pain by various assessment tools. Like various tools are available. With that, we need to assess like Wong Baker scale for children is there, some descriptive pain scales are there, numerical pain scales are there. So with that, we need to assess the degree of pain, and we need to prescribe the appropriate medication directly. We should not jump for the opioids analgesics. It should be, if it is a very acute pain and it is very mild pain, so we should start from the weak opioids, or we can start from the non-opioid drugs. So this is the prescribed prescribe the appropriate medications. This is the three important concepts of the ladder, that is adequate knowledge about the pain, assess the degree of pain, and prescribe the appropriate medication. So next, we'll understand about the analgesic ladder. In the first slide, we have seen the briefly about what is analgesic ladder. So here we will understand what ladder means. So ladder is having three steps. This analgesic ladder moving from 1, 2, and 3. So like 1 is having the dose drugs, which is non-opioid drugs. So this, if a person is having acute pain or having a mild pain, so in that case, a prescribe a non-opioids analgesics. So non-opioid analgesics are analgesics which is having which is also called as a co-analgesics. For example, acetaminophen, brufen, and aspirins. These are the very simple drugs and over-the-counter drugs, easily available. It is safe and effective as first line of treatment. So along with this non-opioids drug, it can be combined with the adjuvant drugs also, adjuvant therapies. Adjuvant drugs are the vast set of drugs which is belonging to the different classes. Although their administration is typically for indication other than pain treatment, but this is also helpful in reducing the pain conditions. And this is also called as a co-analgesic, such as antidepressant, tricyclic antidepressants, anticonvulsants. Some topical anesthetic patches are also available that can be also used as a adjuvant therapy. So, if a patient is having pain and prescribed with the non-opioid drugs with the adjuvant therapy, and still the pain is persisting and it is inclining up, it is not reducing, it is increasing, so then we'll move to the ladder 2, that is known as consisting of medication for the mild to moderate pain, that is known as the opioids drug, which is weak opioids. So weak opioids are having a hydrocodone, codeine, and tramadols, and along with that some adjuvant therapies also can be combined. Then still if the pain is persisting, we'll move and we'll incline towards the upper ladder, which is consisting of drugs which is having a classification called as opioids drugs, that is known as the morphine, methadone, phenylephrine, oxycodone, hydromorphine, and oxymorphone. These are the potent opioids. So this very importantly that, and it is very essential that drugs to be choose appropriately according to the severity of pain, because as many patients will receive opioids, eventually it is essential to balance the optimum dosage with the side effects of the drugs. Moreover, opioids rotation can be adopted to improve analgesic and reduce the side effects. Again, patients should receive adequate information regarding the opioids as well. So this is the revised analgesic ladder. Like I said initially, when in 1986, when the ladder was proposed, it was having a three steps or three ladder consisting what from non-opioid drugs to weak opioids to opioids, and it was unidirectional. But later on it was proposed, it was many contribution has been done and many revision, many modification has been done, and it one more ladder added with invasive and minimally invasive treatments, and it is treated as bidirectional, so which includes nerve blockade and neuroanalysis. So it is added in the ladder to allow for the interventional pain management efforts, that is nerve blockade and neuroanalysis. So there's a certain principles of WHO analgesic ladder, that what and how we have to administer, we need to follow, that it should be followed by the principle that by the clock, by the mouth, and by the ladder. So we will see one by one what is this principle says. By the clock. The clock, it means that something which has been getting scheduled. So to maintain freedom from the pain, and the drugs which is from any ladder should be prescribed on the given time. The time should not be missed when the prescribed time is given. So it should be given on the regularly scheduled time, but it depends upon that how duration it should be given. It depends upon whether the drugs is having a long or short acting preparations. So it depends upon if it is a short acting, tries a time it should to be administered or 4 times, or if it is a very long acting, it can be needed only a 2 times a day. By the mouth. So by the mouth, it means that first of all, it should be preferred route is that the oral route. It is a very conventional and it is a preferred route to use into the variety of setting. If it is not feasible in some patients where oral route is not possible, so in that case, the sublingual can be also uh, achieve and subcutaneous injection. But before intravenous, all this intervention, all these routes should be adopted and should to be get tried. An intramuscular route should never be used. It should only tried either with the mouth or with the sublingual or subcutaneous or intravenous, but intravenous should consider as a last option for that. So this is the analgesic ladder. We have discussed the all the three steps, and it is very inexpensive, and 80 to 90% it is effective when it is optimally utilized. So like we have said that because of the revision, one more ladder has been added. So surgical intervention on appropriate nerves may be provide a further pain relief if drug is not wholly effective. And more invasive routes of administration like epidural may be necessary for the smaller subset of patients. A very important thing is patient education is very much important when we are using with the opioid drugs, when we are giving a patient for pain relief. Opioid drugs should not be prescribed for the longer duration of time, because it is having along with its beneficial aspects that is having its own side effects, and it make the patient addictive for the opioid drugs. So the usage and the side effects of the drug should be clearly stated and explained to the patient and the client. It should not be used or misused or abused without compromising their beneficial aspects. Thank you. Hope you understood the session.